Good afternoon. My name is Renus. I'm an orthopaedic trainee, currently working at North Shore Hospital, actually. But the study I'll be presenting today is part of my doctoral thesis, due next week, in fact, so it's a busy time for me. Most of the work I've did as part of this study, I did under the hat of being a research fellow here at Ko-Awatea. And so supervised by Professor Andrew Hill and a whole lot of orthopaedic surgeons. And so the study I'll be presenting today is tranexamic acid in knee surgery. So I have no disclosures. So total knee joint replacement surgery can induce quite a significant amount of blood loss. And when you think about the type of patients that we're doing this operation on, they're generally older, generally laden with a whole lot of chronic diseases, cardiovascular, respiratory. And so they're probably less resilient towards large amount of blood losses. And so we try to attenuate this by giving them tranexamic acid. Now, what is tranexamic acid, you say? It's difficult to say, but it's a synthetic derivative which binds to lysine. Is a synthetic derivative of lysine which binds to plasminogen. Now, plasminogen is responsible for breaking clots down. So if you think of it, you're taking away the X from the X-men, who's responsible for taking down clots. Okay, so the hope is that we maintain clot architecture and reduce blood loss. Now, there's plenty of evidence to say that it works in cardiac surgery, has been used in the perioperative setting for over 3 or 4 decades in this setting, and there's increasing evidence to suggest that it works in arthroplasty or joint replacement surgery. However, its use remains variable, and so this study showed was a survey of 99 UK centres, arthroplasty centres, asking about their use of tranexamic acid. This study showed that 38% of those centres did not routinely use tranexamic acid. This is also reflected in a survey we performed here, in a national survey among arthroplasty surgeons, asking about various perioperative care practices, including the use of tranexamic acid. And only 46%, just over half routinely used tranexamic acid in this setting. And when we implemented our ERAS pathway, or our standardized perioperative care pathway, back in 2013, although we encouraged the use of tranexamic acid based on the literature and based on our experience, it only moved from 12% pre-ERAS to 1 in 5 patients receiving tranexamic acid. So although there is good evidence to suggest that it works, clinically and in practice, it's not being implemented. So there are various reasons for this, and so some lie in tradition. If it's not broken, why fix it? There's also this theoretical risk that maintaining clot architecture increases your risk of developing clots. And so we know that in knee joint replacement surgery or lower limb replacement surgery, these patients who have these operations are already at a higher risk than the general population of developing clots. And sometimes these clots can then flick off to the lungs and cause more problems. And also the lack of evidence around the dose and timing and the route. At the time of my literature review, there was only a handful of studies which compared topical intra-articular tranexamic acid versus giving it through the drip. And the thought was if you give it locally, as you would local anesthetic, you might have higher tissue concentrations, less systemic absorption, and therefore get the benefits of the tranexamic acid without getting the potential side effects. And also, there's possible benefits around reduced hematoma formation, which is important because, blood is a perfect medium for infection. And so periprostatic infection is equally a catastrophic problem. We can also reduce or potential to reduce swelling around the knee, so less blood around the knee, therefore earlier range of movement, less pain, and also, as we've mentioned, less risk of clot. So with this in mind, we set up a multi-centered randomised controlled trial involving 5 hospitals. Majority of patients were recruited from this hospital, Middlemore, and also North Shore Hospital. Asking the question, is intra-articular, so giving it in the knee, tranexamic acid as effective as giving it through the drip or intravenously when compared to the placebo? We had a standardized anesthetic protocol. In fact, most of the centres had standardized ERAS protocols as part of the National ERAS Collaborative. So spinal anesthesia, no peripheral nerve blocks, intravenous antibiotics, and no tranexamic acid on induction. Our surgery was also standardized. Each surgery was performed as per the surgeon's routine practice. Really, there's not much difference in the actual surgery itself. They had to use a tourniquet. Components were cemented in place, no drains, and the tourniquet had to be deflated at the end of the procedure once you bandaged everything up. We excluded the use of adrenaline in the high-volume local anesthetic. We could have included it, but we decided not to. So we had 3 groups running in parallel. So Group A is our placebo group, so they received normal saline, no tranexamic acid, and they received that through the drip and into the joint at the time of surgery towards the end. Group B was our intra-articular group, so they received the drug into the joint, and at the same time they received normal saline in the drip. Group C was the opposite of B, so they received drug in the drip and nothing in the joint, or saline in the joint. And as part of our post-operative protocols, as per hospital practice, we used aspirin for DVT prophylaxis. We had standardized transfusion triggers, so HP of 80, you received blood. HP of 100, and if you had cardiovascular problems or you were symptomatic, you would also receive a transfusion. Our primary outcome measure was estimated blood loss, and so this was based on your hemoglobin drop, so preoperative HB minus a postoperative HB. This is a well-validated method of calculating estimated blood loss if you're not measuring it directly, and it takes into account your blood volume, so age, gender, gender and BMI. And we also had secondary outcomes that we also measured. So here is our consort stadium. It's a bit busy, but essentially we had 23 patients in Group A, or the placebo group, 60 in Group B, and 51 in Group C. And exclusion, or reasons for exclusion, are listed there. This is a box chart which demonstrates estimated blood loss. So Group B and C towards the left, and marked by the asterisks, demonstrating significantly less blood loss compared to our placebo group. Put in numbers, Group A demonstrated roughly 1,000 mils of blood loss compared to 720 and 749 in the 2 treatment groups. Our secondary outcomes, there were no differences. This is just interesting, I've highlighted here. In fact, we experienced 2 PEs in our intra-articular group and 1 in our systemic group, none in our placebo group. And then this table, although busy, just demonstrates there were no differences in range of movement through post-operative days 1 through 3. So, in conclusion, tranexamic acid is effective at reducing blood loss in knee joint surgery. A single dose of 1.5 grams given either through the drip or intra-articularly is equally effective, and there were no differences in secondary outcomes. So I'd like to thank Kwa Watia for helping me get through the research, and also all the orthopedic surgeons involved, and also Irene, who's I've heard has left, so that was a bit sad to hear, but she was very helpful in helping with the statistical analysis of the paper.